Has it gone red? I can't see where the recording thing is. Ah, okay, cool. So recording started and Sylvia's just kind of gone really big on my screen. Okay, she's gone away now. So hi everyone, I'm Niraj. I'm going to be teaching you about acute kidney injury today, and then Sylvia's going to take over later and talk you through some orthopedics and some hip fractures. So apologies that this isn't as interactive as I'd like it to be in terms of the topic, but feel free to stop me at any point and ask questions whenever you need to. So firstly, just going to talk through what acute kidney injury is and why it's such an important topic to learn about. So it's really important because it does come up in OSCEs and in SBAs quite often, but more importantly than that, it is a really common presentation in clinical practice. So an acute kidney injury is a sudden decline in renal function from a person's baseline. So it's really important that you remember that it's from somebody's baseline renal function and that it's a sudden decline, because anything more than 3 months, we generally go into kind of chronic disease, kidney disease territory. So it's a less than 3 month decline in renal function from baseline. And it's defined by the criteria that you see on the right. So I would say that these are kind of here for your reference. I'm not going to talk through all of them, but the main kind of takeaways from these criteria are basically the creatinine rise figures. So 1.5 to 2 times is a stage 1 AKI, 2 to 3 times is a stage 2, and over 3 times is a stage 3 AKI. And then you've got your urine output criteria as well. So just have a look at these in your own time, because I'm not going to spend time talking through them. But this is a really helpful way to categorize AKIs, and this is kind of what's used universally in terms of categorization. And this is really important because actually 1 in 5 acute admissions to hospital have some degree of AKI. And we talk about things like MRSA all the time in terms of things to watch out for. But AKI is actually 100 times more deadly than MRSA, and it has quite a high mortality rate. So it's 23.6% across all 3 stages. But if somebody goes into stage 3 AKI and requires dialysis, then actually the mortality jumps up to 50 to 60%. So it's a really important thing to be aware of, because in a lot of cases, AKI is preventable and quite treatable too. So guys in the chat, if you just want to have a think about the functions of the kidney in terms of kind of what it does, what it gets rid of, what it's responsible for doing, could you just post some ideas of kind of what might happen if somebody's kidneys stop working all of a sudden? If somebody has a rapid decline in renal function, what could happen to them? Yep, so good, Nadia. That's a really, really important one. So hyperkalemia, so electrolyte disturbances in general, and hyperkalemia is the one that we're mainly worried about. MOX, yep, fluid overload. So obviously the kidneys are there to get rid of fluid. If that's not working, then obviously, if they're not working, then obviously you're going to get fluid overloaded. What else do the kidneys get rid of? Yeah, exactly, Celia. So toxins, and the main one that we think of is urea. So this is a nice way to think about the, yeah, exactly, MOX, urea. So this is a nice way to think about the complications of AKI. So you've got your metabolic things, so things like uremia, hyperkalemia, and acidosis. So uremic symptoms, you might get things like encephalopathy, so confusion, you might get itching and things like that. Hyperkalemia, as you said, Nadia, is really dangerous because it can lead to arrhythmias. And I've got a tiny bit on the management of hyperkalemia later on, and metabolic acidosis, which again isn't great for people. Volume overload, like you said, MOX, you can get pulmonary edema and impaired oxygenation. And actually, ultimately, if an AKI is really bad or it continues for a really long time, the person's kidneys might not recover, and they could go into end-stage renal failure and require permanent renal replacement therapy, so things like dialysis. So now we're going to spend some time thinking about the causes of AKI. So does anybody know a kind of a way to categorize the different causes of AKI? Yep, good, Mock. So you can have prerenal AKI. What does that mean? Or anybody else? So you can have a prerenal AKI. How else can we categorize acute kidney injuries? Yep, so I think Mock's got it, and that's probably because he's in 5th year. So you can categorize AKIs into 3 different types. Exactly, Celia. So you can have your prerenal AKIs, like Mock said. You can have intrinsic kidney disease, and also postrenal AKIs. So prerenal AKI means that there's something wrong with blood getting to the kidneys. So that's usually to do with the veins or the arteries of the kidneys. And it can also be due to the blood supply to the glomerulus itself, which is something we'll talk about in a minute. You can have intrinsic kidney disease. So these are things that are actually inside the kidney that are going wrong. And you can have problems with the glomerulus. And we're not going to talk too much about these today. We might do it in a future lecture. The interstitial, so that's the place between all of the tubules. Or you can have vascular issues inside the kidney as well. And then, like Celia said, you have your postrenal causes of AKI. So that's basically when you've got an obstruction somewhere in the urinary system, which leads to, sorry, that's my phone, which leads to urine building up and going back into the kidneys and stopping them from working. So we'll just have a quick chat about prerenal AKI. And as I said, please do stop me at any point if you want me to explain anything properly. More properly rather. So prerenal AKI is a clinical diagnosis. So it's usually something that actually based on kind of clinical signs and a history you can diagnose. Yes, Mox, you've got your hand up. Feel free to unmute.
Sorry, that was an accident.
All right, so accidental hand up, just to cause trouble. So as I was saying, prerenal AKI is a clinical diagnosis. And you can think of prerenal AKI as pretty much anything that's stopping blood getting to the kidneys effectively. So if somebody's hypovolemic or dehydrated, they're not going to be perfusing their kidneys properly. So that's a cause of prerenal AKI. If they're septic, then all of their capillaries are leaking and they're in shock. They're not going to be getting enough blood to their kidneys. So that's also prerenal AKI. If they've got a decreased effective circulating volume. So by that, we mean there's enough liquid in the body, but not enough of it is in the blood vessels. So things like liver disease, which causes ascites, drawing fluid out of the blood vessels, severe heart disease, things like that can cause a prerenal AKI. And this is a really important one, impaired renal autoregulation. So I'm not going to go through the physiology that you would have learned in 1st year. But remember that the glomerulus is generally really good at regulating its own pressure. The kidneys are really good at regulating the pressure of blood that goes through them. And they do that by constricting the afferent and the efferent arterioles of the glomerulus. So normally what happens is that prostaglandins can act on the afferent arteriole by dilating them. So if you dilate the afferent arteriole, then you've got more blood going into the glomerulus. But if you take NSAIDs, then that stops the production of prostaglandins, and that means that you get constriction, and that isn't good in terms of maintaining the glomerular filtration rate. So it's not really a problem for people like us who we hope have functioning kidneys, but it can be a problem if somebody's unwell and they've already got a bit of dehydration, or if they've already got a bit of chronic kidney disease, and then you give them an NSAID and then it tips them into an acute kidney injury. And another really, really important one is ACE inhibitors. So ACE inhibitors can decrease the GFR as well. So it's really important to remember. And again, if you look up the physiology of that in your own time, then it will make a bit more sense. Does anybody know any times where we actually give people ACE inhibitors or ARBs when they have kidney disease? So generally, acutely, we avoid them because they can cause an acute reduction in GFR. But there are times where we do give them. Yeah, exactly, Nadia. So diabetic kidney disease is a good time to give an ACE inhibitor or an ARB. Any chronic kidney disease, really, is kind of an indication for an ACE inhibitor or an ARB. And the reason for that is that although it decreases GFR, James as well. So again, in scleroderma and renal crises, I never really understood why either. I just learnt it. But in chronic kidney disease, you do get a small decline in GFR when you give somebody an ACE inhibitor. But actually, what an ACE inhibitor does is it dilates this efferent arteriole. So it decreases the pressure in the glomerulus, and that reduces damage. So if you take away one thing, just remember that don't use ACE inhibitors in an acute kidney injury or when you've got somebody acutely unwell with any degree of renal impairment. But when it comes to chronic kidney disease, ACE inhibitors can be good things because they limit damage to the kidneys. And like Nadia said, they're used in diabetic kidney disease because they reduce the amount of protein that's leaking out through the glomerulus. Okay, so while your prerenal was a clinical diagnosis, your intrinsic renal disease is more of a biochemical diagnosis where you have to look at the urine to see what's going on. Now, you can have issues in these three compartments. You can have it in the glomerulus, so acute glomerular nephritis. You can have some kind of vasculitis or kind of microangiopathic anemia causing issues in the kidneys. But we're not going to focus on these two because the vast majority of intrinsic AKI is due to issues with the tubules. So that's the in the nephron, or the interstitium, which is the bit between the tubules. So that's what I'm going to focus on now. The three main things you need to know about are acute tubular injury, previously known as acute tubular necrosis, acute interstitial nephritis, and the role of nephrotoxins and what kind of nephrotoxins there are intrinsically and extrinsically to the body. So firstly, acute tubular injury. This is the most common cause of AKI, and it's usually caused by a really prolonged prerenal AKI. So if you imagine, if you've got low perfusion of the kidneys for a very long period of time, then eventually the tubules are going to die or get injured. So then you go from a prerenal AKI into having acute tubular necrosis. Can also be due to sepsis because of all of the inflammatory changes that happen in the body, and also drugs, which we're going to go through on the next slide. Now, what's really important in terms of exams, I'm not sure about clinically, but what's really important in terms of exams is that if you've got an acute tubular injury, there are certain things you can look for in the urine. So remember I said intrinsic AKI is usually a urine diagnosis. This is a muddy brown cast in the urine, and that's basically loads of dead cells from the tubules. So loads of dead cells that have collected together in the shape of the tubule and kind of been expelled out into the urine. So on microscopy or in an exam question, if you get muddy brown casts, then it's acute tubular necrosis. You'll also see a high urinary sodium because the tubules are dying, so they're not able to hold on to that sodium and they kind of let it all out into the urine. Now, often acute tubular injury is reversible with supportive management, so things like hydration and the management that we're going to go through a bit later on. This is here for you to look at in your own time. So there are lots of different types of urinary casts, and it's good to be familiar with them for exam questions. So that's the tubules. The next thing to talk about is acute interstitial nephritis. So this is a problem with the interstitium, the bits within the tubule, between the tubules. Now, acute interstitial nephritis is mostly drug-induced, and it's kind of an allergic type reaction to a drug, usually things like penicillins, but also things like NSAIDs as well. So people with acute interstitial nephritis present with this sort of allergic type picture with eosinophilia, so they might have high eosinophils in the blood, but also in the urine, and with things like fever, rash, and joint aches as well. And again, these are the things to look out for. So white cell casts in the urine, and white cells in the urine, but without any bacteria. And usually, like any allergic reaction, these people are steroid responsive. So that's that. This is really important. So the nephrotoxins. So nephrotoxins are things that are toxic to the tubules. Now you have some that are intrinsic, so some that are produced within the body, and some that are extrinsic. So these are things that we kind of give to people. Intrinsically, things like myoglobin, if you've got breakdown of muscles, rhabdomyolysis, for example, after a fall, or hemoglobin, if you've got a hemolytic anemia, things like paraprotein in myeloma, and in things like tumor lysis syndrome, which you'll come across in hematology, you can have crystals forming which damage the tubules. This is a typo. This should say acyclovir, but acyclovir is an extrinsic nephrotoxin. It can crystallize inside the tubules and cause an AKI. And then lots of drugs can cause, lots of drugs are nephrotoxic. So the ones to remember are the aminoglycosides, things like gentamicin, which are tubular toxins, as well as contrast, so radio contrast and PPIs. And again, just bear this in mind, because if you have somebody with renal impairment who's unwell, then obviously you don't want to be giving them these things, or at least not in high doses, or with careful monitoring to make sure that you don't make things worse. So can anybody tell me what's going on here? This is a urine sample. So Celia, it could be muddy brown casts. It could be. You would have to have a lot of casts for it to colour the urine that much. Usually casts are things that we can see microscopically, but not a bad idea. Okay, so this is what we call Coca-Cola urine. So it's not quite as dark as Coke is, but it can get quite dark. And usually you see this picture in things like rhabdomyolysis. So if somebody's had a fall, so like Sylvia's going to talk to you about neck of femur fractures, this should form part of your workup, taking a urine sample and looking at kidney function. Because if they've been lying on the floor for a long time and their muscles start breaking down, all of that myoglobin goes through the kidneys and basically poisons them. You also get this in malaria because of hemolysis. You get dark urine. And then you have your post-renal causes. So we said pre-renal is a clinical diagnosis. Renal, intrinsic renal, is a biochemical diagnosis. Post-renal is a radiological diagnosis. So this is probably the easiest diagnosis to make, because you can do a scan and say, oh yeah, this is a post-renal AKI. I'm not going to go through all of these. This is kind of for your own reference. But all I'm trying to kind of get at here is you can have obstructions in the renal tract because you've got things blocking the renal tract, so things like stones or clots. You can have things in the wall of the ureter, for example, like tumors causing a backup of urine. And you can have things outside the renal tract causing compression. So if you've got prostate cancer or prostate hypertrophy, that's going to squeeze the renal kind of the urinary system and cause a backup of pressure. If you've got tumors, so for example, if you've got really big colon cancer, then it can obstruct the urinary system and cause a post-renal AKI. So does anybody want to tell me what kind of scan this is and what it's showing? Let's start off with the first question. So what kind of scan is this? Yeah, Mox, so it's a CT. Anybody else? Celia, yep, it's a CT, so it's a contrast CT. Yeah, Nadia, I think, yes, it's a coronal view, it's a contrast CT. And it's a CT of the urinary system. So you can see the kidneys here. And what can you see about these two kidneys compared with each other? So these are the kidneys that I'm highlighting here. What do you think is happening? Abnormal kidney? Yeah. On which side? Maybe cysts, okay. Celia. Left kidney, yeah, thank you, Sylvia. Yep, so the left kidney looks abnormal. That's a good start. So it's a left kidney because we're looking at a CT. This renal pelvis is dilated and the kidney is very big. So this is called hydronephrosis, and that means, it means basically that there's a backup of urine into the kidney, which is causing high pressure in the kidney. The pressure of the urine will actually exceed the pressure in the vascular compartments of the kidney and stop it from being able to do its job. So this is a classic post-renal AKI caused by maybe a stone further down in the renal tract, causing urine to back up into the kidney. So this would be your classic post-renal AKI. And to deal with this, you could put a nephrostomy tube directly into the kidney to decompress it and try to limit any damage to the kidney. Again, this table on the right, I want you to have a look at in your own time. But the general diagnostic approach is basically what I've been trying to hammer in from the beginning. You start off with a clinical assessment of the patient. This is how you pick up a pre-renal AKI. So you're going to do your fluid status and a full examination of the person. Are they overloaded? Are they dehydrated? Do they look like they're septic? And then you move on to your biochemical tests to confirm that you have an AKI, but also to check whether it's intrinsically renal. So you want to do your blood and urine tests. So serial Usenes to look at the trend. VBGs for fast results. So somebody said about hyperkalemia earlier. If you're worried about hyperkalemia, do a VBG because then you'll get your results straight away. And also do an ECG to look for any arrhythmias. Urine dip. While I'm talking, if somebody could just type in the chat what we're looking for mainly in the urine dip. And the urine sodium and microscopy are really helpful. So microscopy to look for the casts, and the urine sodium to check whether it's a pre-renal or an intrinsic renal issue. If it's pre-renal, the the kidneys are going to try and hold on to the sodium because, as you know, when you're dehydrated, you do try to retain sodium. So your urine sodium should be low. Whereas if it's an intrinsic issue, especially a tubular issue, the kidneys aren't able to concentrate urine, and there's going to be lots of sodium inside the urine rather than little. And then you can have a look at microscopy in your own time. And then you move on to imaging to see whether this is a post-renal AKI. So you want to do a bladder scan, see if the person's retaining urine for any reason, and an ultrasound of the urinary tract, and maybe a CT like we saw previously. And really, if you can't figure out what's going on and it's really bad, then you probably want to do a biopsy. More specific tests can be done depending on what you think the cause is, but you can read this in your own time. Are there any questions about, well, if there are any questions about diagnosing an AKI or finding the cause of it, please do post them in the chat and I'll come to them in a second. So finally, before I hand over to Sylvia, you figured out that somebody has an AKI, you figured out what the cause of the AKI is, but how do you manage them? And, you know, as I said, AKIs do have a really high mortality, so it's important to know the management well. So the first thing you want to do is hold nephrotoxic drugs. So in the chat, can you give me some examples of nephrotoxics that we've talked about before? Yeah, good, Nadia. So PPIs, usually actually not one that we think of a lot, but yes, they are nephrotoxic. Yep, aminoglycosides, so things like gentamicin. Anything else, really commonly used drugs that people might be on pre-admission? Radio contrast, good. I think Mock just typed something. Sorry, Sylvia, because we started a bit late. I'll carry on for 5 minutes. NSAIDs. So NSAIDs are really important. People come into hospital on all kinds of drugs. They come in on NSAIDs. They might be on ACE inhibitors and ARBs, which you need to stop. They might be on Yep, Yusuf, exactly. They might be on metformin, which is another one that you need to stop as well. So the best way of remembering this, or the way I remember it, is stop the damn drugs. So diuretics, generally avoid, unless they're really, really volume overloaded and they need diuresis. ACE inhibitors and ARBs, you just should not give people in AKI. Metformin, not because it's nephrotoxic, but because it can accumulate and cause a lactic acidosis, and that can exacerbate the metabolic acidosis that they might already get. So this is one for endo and also for renal, I guess, but you shouldn't use metformin in people with poor renal function. So anybody with a GFR of less than 30 shouldn't have metformin generally. And NSAIDs, like you said, Celia. So stop all of these with a view of starting them again when the renal function returns. And be careful with starting any of these drugs too. And like you guys have said, be careful with starting aminoglycosides or drugs that might accumulate in renal failure. So if you've got somebody who's septic and in AKI, you need to think very carefully about what antibiotics to start. You will see quite commonly people on gentamicin with an AKI, and that's because you have to do a risk-benefit analysis and think, okay, well, is the risk of kind of wiping out their kidneys, is it justified in the face of how severe the infection is? So there is a bit of a trade-off there. The second thing you need to do is manage the underlying cause. Okay, so we talked about some of the causes of AKI. Not all of them are kind of manageable, but some of them are. So if they're septic, you treat them for sepsis, you do all sepsis 6 and give them antibiotics. If they're generally dry and dehydrated, you want to give them fluid resuscitation. If you think the AKI was caused by something, so, oh, they just started an ACE inhibitor and now they're in an AKI, stop it. And that's a really important one that I think people often overlook, stopping anything that could have precipitated the AKI. If it's a post-renal AKI, you need to relieve the obstruction. So a nephrostomy done by interventional radiology, or a catheter if it's a prostate problem. And you need to prevent exacerbating the AKI by basically protecting their kidneys in any way you can. Then there are more specific managements. James has kind of said, James said in a couple of things like scleroderma, renal crises, you might give ACE inhibitors, which is counterintuitive, but this is just basically a basic overview of how to manage an AKI. After you've done that, so you've held your nephrotoxics, you've managed your cause, you need to monitor and manage for complications. So look at their userness frequently, see what they're doing. Is the AKI progressing? Are they getting an electrolyte disturbance? If they are, if they're hyperkalemic, then refer to my talk a couple of weeks ago. But generally you want to do an ECG, protect their heart against any arrhythmias and lower their potassium. If they're fluid overloaded, you want to fluid restrict them maybe, and maybe give them some diuretics. You might want to also consider putting them on renal replacement therapy, which is the final thing I'm going to talk about. And you need to be careful of rebound diuresis. Does anybody know what this is? Anyone know what rebound diuresis is? So basically, when somebody's kidneys stop working for a while, James obviously does know, and he's about to put it in the chat, I think. It hasn't come through yet, but yeah, exactly. So not only obstruction, but even if it's not a post-renal AKI, even if it's an intrinsic or pre-renal AKI, the kidneys sort of go into overdrive at first, exactly, and people can actually like pee out like liters and liters and liters of urine, and then they're at risk of becoming dehydrated and putting themselves back into a pre-renal AKI. So you need to watch for that and make sure that they have a very careful fluid balance chart set up. So renal replacement therapy, this is the final thing I'm going to talk to you about. So renal replacement therapy is taking over the job of the kidneys. Usually we're talking about hemofiltration. So it's a bit different from hemodialysis, but it's pretty much the same concept. But in hospital, you usually do hemofiltration in intensive care. So the indications for renal replacement can be pretty nicely remembered by AEIOU. So severe acidosis that's not responding to medical treatment, electrolyte disturbances that are like severe hyperkalemia that are not responding to medical management, intoxication with these drugs that can damage the kidneys or can damage other things. So these are the slime drugs: salicylates, aspirin, lithium, isopropanol, which nobody should be drinking, methanol, if people have drunk methanol by accident, and antifreeze, ethylene glycol. These are good things to remember: AEIOU and slime. Fluid overload, that's refractory to diuresis or medical management, and uremia. So things like encephalopathy, confusion, itchiness, pericarditis, which you get in uremia, that would be an indication for renal replacement. So that's kind of my overview of acute kidney injury. Sorry that there was so much in there, but I hope that you find the slides useful and that you've at least kind of had an overview of AKI. I'm going to hand over to Sylvia now to talk to you about probably a lighter topic, some ortho. But in the meantime, if you do have any questions about what I've just said, please pop them in the chat. And equally, if you have any questions during Sylvia's, then I'll try and get to them as well.
Perfect. Thanks, Niraj. Let me know if you can't hear me because I've got my headphones in. But yeah, brilliant. I know that was like a really heavy kidney topic. So don't worry, guys. The next kind of second half of this is going to be nice and light, nice and straightforward, hopefully. So in terms of what we're going to cover today, it will be all around hip fractures. The content I'm going to cover is going to be all of the key stuff that you'll need to know for hip fractures. So it's all fairly straightforward, I'd say. A real favorite for SBAs, OSCEs as well. So good stuff to get to grips with quite early on. And plenty of hip x-rays that you can kind of have a look at through the presentations as well and get quite familiar with those. So we're going to jump straight in with a scenario. I know there's 4 of you guys still here with us. So if you all just have a read of this and then drop in what answer you guys think it is, please feel free to have a go, even if you're a bit lost and have no idea how to go about it. That's the whole point of the presentation. But I'll give you guys a few seconds, drop in what you might think it is, and then we can move on with discussing the answer. Fantastic. Thank you, Celia. So Celia started off. Brilliant. I'll leave a few more seconds if Yusuf is still with us to drop something into the chat. All right, so most of you guys said C. We'll have, oh, and Yusuf, oh, okay, so we've actually got an even split between A and C. Brilliant. Thanks, guys, for all responding. Brilliant. So the answer is actually C. So well done, those of you that put in C. But we'll have a look at why. So in terms of those of you that did say C, and perhaps those of you that said A that now may think it's C, what clues in this question actually points towards a right intracapsular neck of femur fracture? Externally rotated. Exactly, yep. Good. Are there any other kind of perhaps even patient demographics here that are making you guys think it's more likely a neck of femur fracture? Older, fantastic for the age. Great, Celia. All right, so there are a couple more there. Brilliant, guys. There are a couple more in there as well. So Celia, you said older, so age of 64. So 64 is a postmenopausal age, and she's also a female, which is another really important point. Why are you more likely to have a neck of femur fracture in a postmenopausal female? Any thoughts? A bit of a cross to endo, but still relevant here. Osteoporosis, exactly. High risk of osteoporosis. Thank you, Nadia. Yeah, brilliant. The fact that she had a fall, again, another risk factor there. And like you were saying, Nadia, earlier, shortened and externally rotated. That's a classic. If you see those two words, your neck of femur fracture alarm bells need to start ringing. All right. So along the same vein, can you guys, I mean, we've looked at a lot of them, but can you guys throw out some risk factors for neck of femur fractures? That hashtag there is shorthand for fracture. I've used those in the slides. Yeah, exactly, Niraj. Thank you. Your neck of femur alarm bells always ringing. Great sign. An orthopedic in making. So we've already discussed a few risk factors already. So malnutrition, nice, good. And that might be reflected in a BMI perhaps as well. Any other ideas, guys? Age, postmenopausal, exactly as we've discussed. Femur over male, exactly. Especially with, as we were saying, the risk of osteoporosis. And also don't forget, an older age, you're going to be a lot more kind of, you know, generally speaking, fragile, more likely to fall as well, which is another risk factor. Perfect timing, Celia. Any medicines that could affect bone health? Okay, we'll go on to the ones that I've got here. So as we discussed osteoporosis, osteopenia as well. Just briefly, what's the difference between osteoporosis and osteopenia? If you guys want to put that into the chat. We've discussed increasing age falls, a low BMI as well, makes you a lot more fracture prone, and the female sex as well. What's the difference between osteoporosis and osteopenia, guys? Does anyone know the bone density thresholds that we use? Okay, no worries if not. So osteoporosis is when you've got a bone density score that's below -2.5. That's a really important threshold to remember. And excellent, Mox. Okay, you guys know it, brilliant. So Mox has come in osteopenia -1 to -2.5, brilliant. And osteoporosis is below -2.5. So I would say just remember those by heart. Excellent. So we'll go on. So now an image here. Do you guys want to point out anything that you can observe from this X-ray? It can be simple, it can be even the diagnosis. What features can you see here? Oh yeah, absolutely. If someone feels courageous enough to want to even present this X-ray, then feel free. Agreed. Hip fractures are a big fave in OSCEs. I can tell you that much. Mox just hit the nail on the head there. Brilliant. Right neck of femur fracture, brilliant. Thank you, Celia and Mox. Cool. Okay, so there are a couple of other features. So you guys have got pretty much what's going on. It's a displaced intracapsular neck of femur fracture, and it is a complete fracture because if you look at that fracture line, it's going through completely transverse through that whole bone there. There's also the Shenton's line that's important to look at. So don't forget, this is when you have that line going from the lesser trochanter, I'm trying to find the pointer, but I can't get it, the lesser trochanter all the way along that inner femoral head and the inferior edge of the superior pubic ramus. So have a look at Shenton's line so you guys remember. But when you have a break in this as well, that's one of the key features of a neck of femur fracture. So that's another thing that you can look at. And also, if you think about the fact that, you know, the leg is shorter, it's externally rotated, then the lesser trochanter as well on that right side, you can see, is more prominent. And that's because of that external rotation. So those are all features that kind of point towards this displaced intracapsular right neck of femur fracture. So do imprint this image into your mind and, you know, remember what kind of features you're looking for to differentiate those. Does anyone know what the classification that we use is, specifically in intracapsular neck of femur fractures? Yeah, I can use the laser pointer, but I was trying to. Okay. It didn't show up when I had it on a split screen. Now we've got it. Brilliant. Thanks, Niraj. Weber's is a classification that we use, not for intracapsular neck of femur fractures, but does anyone know what we do use Weber's for? It is the lower body. That's not a very good clue. Sorry, Niraj. It's a good attempt, though. All right, so it's called the Garden classification, which is what Niraj was trying to point to. But does anyone know what Weber's is? Hauser. Yeah, exactly. That's what that emoji suggests. Anyone know what Weber's classification is used for? A bit more distal than the hip. So that's the ankle. Yeah, brilliant. That's the ankle. But unfortunately, today's just about the hip. Sorry much to disappoint, but maybe I can visit the ankle in a future presentation. Good. So the Garden classification is actually very simple, but I'm someone that actually found it very confusing. So if you literally just remember, it goes from 1 to 4. Remember that 1 and 2 is not displaced, and 3 and 4 is a displaced fracture. Is a good starting point. And then the niche differences is then, as this table basically says, 1 is not displaced, but an incomplete fracture. So the fracture line doesn't go through both cortices. Garden classification number 2 is a complete fracture, but still a non-displaced fracture. And then 3 and 4 is completely displaced, but the difference is actually they both have a complete fracture, but the extent of displacement differs. So number 3 is slightly displaced, whereas 4 is completely displaced. I find 3 and 4 a bit more difficult to differentiate between, but often if it looks completely like it's going in 2 different directions, you know it's obviously going to be a classification that comes under 4. But if it's slightly displaced but not so obviously, then 3. But I would say those are a bit more harder to differentiate between. Something that one of the orthopedic trainees told me, which was quite useful, was that when you're looking at an X-ray, if you can actually follow the bone cortex and you find that there's a break in it when you go near the fracture, then that suggests there's some level of displacement. Because there were times I was describing some X-rays as not being displaced, and actually they were. So bear in mind that even the smallest displacement still counts as a displaced fracture. I hope that makes sense. For some people, looking at these images make a lot more sense. You can quite obviously see the extent of the fracture line in 1 and 2, and that they're very minimally displaced, if any displacement at all. And then in 3 and 4, you've got both being somewhat displaced and having a complete fracture line through both, but actually number 4 is a lot more significantly displaced than 3 is. Let me know if that doesn't make sense. You guys will have the slides, so you can take some time. I feel like I had to really stare at these to get my head around it last year, to be honest. Okay, cool. Let's move on to the next SBA here. Again, I'll give you guys a minute or so to drop in your answers. Again, please all answer. It doesn't matter if you're right or wrong. So we've got 3 for D so far. Moksha, are you going to go with the crowd or choose a different letter? D, okay, going with the crowd. So everyone's decided to go for D. Let's find out if you're all right. Okay. So it is actually B. Yeah, nice one, Niraj. C, budding orthopedic. So of course you've got it right. Right extracapsular neck of femur fracture, right? So now that you guys know it's extracapsular, any ideas on what makes this extracapsular and not intracapsular? I mean, I guess the answer is kind of in the name. And for bonus marks, if anyone knows what type of extracapsular fracture this is, please feel free to drop it in. All right, we're going to have a look at it in the next slide anyway. The one point I was going to make actually when we're here, I really should be giving you 2 views of X-ray. So just remember, whenever you're presented with an AP pelvic X-ray like is in this slide now, you always want a lateral view. And I would say that's just rule of thumb in any kind of ortho imaging. Always remember you want 2 views, and often this will be an AP view and a lateral view. Excellent, thank you, Nadia. It's below the intertrochanteric line. Fantastic. So you're taking me nicely to this slide. So this is just really important to know. It's actually quite straightforward, but once you've seen this, you will remember it. Intra is this long explanation that I took off Teach Me Surgery, but basically it's the yellow bit. So the intracapsular falls below the head of the femur and above that intertrochanteric line, so everything you can see here. And then extracapsular is everything that comes below the intertrochanteric line up to 5 centimeters below the lesser trochanter. As you can see, I've really elegantly indicated that here. And then remember that extracapsular is split up into 2. So you've got extracapsular fractures that fall into the intertrochanteric line here. So you'd call that an intertrochanteric fracture. And then you've got subtrochanteric, which is basically everything below that intertrochanteric line up to 5 centimeters distal to the lesser trochanter. That's like a lot of words, but if you literally just remember this diagram and think of this yellow as being intra, and remember that everything below this yellow counts as extracapsular, and that extracapsular can then be split into 2 specific terms, which is intertrochanteric and subtrochanteric, then it's nice and simple. I hope that makes sense. Just remember this diagram, to be honest, and you can't go wrong. And do remember that the Garden classification applies for intracapsular fractures. So there's no, I'm coming to it, Niraj. Remember that Garden classification only applies to the intracapsular bit here. Yeah, no spoilers. So I'm going to start off with which one's more important to know about, whether it's intra or extra. Which one do you think we're more worried about? I mean, it's a 50-50 guess. Even if you don't know, guess one of them. Intra, so 2 people have said intra. Do the other 2 agree? Intra, oh yes, Celia has a good idea why. Cool, okay, you guys all know your stuff, brilliant. So you said blood vessels. Do we know what blood vessels? Do you want to expand on that a little bit? What are we worried about happening with intracapsular fractures? Excellent, we've got a retrograde blood supply to the femoral head. Excellent, Mox, correct. What does that predispose us to in terms of a fracture there? Yeah, exactly, AVN, so we call that avascular necrosis. AVN is what you'll see it abbreviated to. Fantastic, exactly. So that's why we're much more worried about intracapsular fractures. This is a bit of a niche question, but does anyone know what that blood supply is? That retrograde blood supply? Do you know what artery supplies? There's a couple, but the main one. No worries, if not, it's not key to know, but nice to know. So it's the medial circumflex femoral artery. So that's the main retrograde circumflex. Fantastic. Celia knows her femoral anatomy, medical femoral. Yeah, almost. Not quite medical, but yeah, medial femoral, medium circumflex femoral artery. Okay, fantastic, guys. You guys know your stuff. Remember, AVN is normally, and this applies to other fractures as well, like the talus, the scaphoid. AVN is one of the key things that we're worried about. So good to know. No worries, Moksh. Okay. Next, scenario 3. Have a read, A or B. I've just looked at the time and realized I've got 3 minutes left, so we're really gonna plow on. Okay, Nadia's gone B. I'm gonna give a few more seconds for you guys to fall on A or B. B, B. Okay, cool. Well, it was actually kind of a trick question. So you guys are kind of right going along B, because as you'll see, actually, we do pretty much go in with semi-replace. Nice. So we pretty much do treat this as an intracapsular fracture. We always want to replace. There are exceptions to when we'll actually fix. Yeah, me too, James. I'm pretty sure you've given us a trick question before. So I was going to ask you what kind of things you guys might want to know when it comes to whether we're going to fix or replace, but I'm going to just move on to that slide now. So in terms of fixing, there are 2 different ways of thinking about it. You can think about it as when it falls into garden 1 or 2, what will I do? If it falls into 3 or 4, what will I do? Another way to think about it is just intracapsulars always replace, unless it's a young patient. That's probably a lot more of a straightforward way to go about it. So as I said here, you're fixing with cannulated screws if it falls within garden 1 or 2. So that's when you've got very minimal displacement, not much damage, and younger patients. Just remember, the key thing here is cannulated screws if it's a young patient. If you try and replace the hip joint in a very young patient, they will need a revision, pretty soon. So that's why we don't try and replace those at such a young age. When it comes to replacement, you're kind of thinking along the lines of garden 3 or 4, and there are 2 options here. So you've got hemiarthroplasty and total hip replacement. Does anyone know very quickly when we may choose a total hip replacement over hemiarthroplasty? So there's actually a bit of a criteria that we need to go by and make sure that the patient meets. Any ideas what this could be, or even, guess? Oh, that's a brilliant poem. Thanks, Niraj and Moksh, for that. Age. Nice. Yeah, we've got to consider the age. I'm going to show it up because I know we haven't got much time. So these are 3 criteria that the patient absolutely has to meet in order to have a total hip replacement. So please note here that all 3 criteria need to be combined. It's not one or the other. I'm going to leave that there. I'm going to move on to the next slide now. I've got some images of what these replacements actually look like on X-ray, so that you guys know these as actual images and what they actually do as opposed to just words. And this is what I said. Intracapsular, we replace. If they're young, we use cannulated screws. Okay, I'm going to speed up now. Any ideas on what management for extracapsular is? Is it fixing? Is it replacing? Do we use another replacement? Is it cannulated screws again, or some other kind of fancy equipment? Fix. Brilliant. Yes, it's fixing. There are 2 types that we use to fix. I would ask you guys if we had some time, but I'm going to show you guys instead. So dynamic hip screw and intramedullary nails. They are the 2 main ways that we treat extracapsular neck and femur fractures. And I've put on here when we use each. Parsons likes these. Very useful to know, learn them, basically. Again, I have some pictures for you guys to kind of be able to visualize these. Okay, last couple of SBAs now, guys. Cool. Have a read, chuck in your answers. Okay, so 2 people have gone B. In the interest of time, I'm going to show you guys the answer. So it is actually D. You can immediately start weight bearing, and it's very important. Excellent, Niraj, thank you. So it's really important you start weight bearing, and this is to encourage bone to remodel and allow for that implant to work, to allow the joint to start working straight away. So I know that when you first think of this, you kind of think, you need to rest up a bit, you probably need to take it easy, but actually, as soon as you've got that total hip replacement, you need to get moving and allow the bone to start remodeling to allow optimal function of that hip replacement. Remember that's a fact that they like quizzing, so learn that. Okay, so we spoke about a few of those managements and approaches very quickly. Which one is this? So we spoke about hemiarthroplasty, total hip replacement, cannulated screws. We spoke about dynamic hip screws and the intramedullary nail. Any ideas on what this one is? Total hip replacement looks very similar. So this is actually the hemiarthroplasty, and this is something that I didn't actually realize till quite late. The hemi part of hemiarthroplasty is actually the femoral head is replaced. So if you can see here, it's actually the femoral head that's replaced, whereas the acetabulum is, hasn't really been touched here. And you'll see eventually how the total hip replacement differs from this. So just remember, it's the femoral head here. That's the metal bit. The acetabulum is still the bone. That's not been replaced. Okay, cool. The left and the right, they're 2 different ones. Which one do we think the left is? Perhaps I'll tell you guys, one is an IM nail and one is a dynamic hip screw. So which is which? The left side, what do we think it is? Dynamic hip screw on the right. Oof. Is it Izzy? Let's see if anyone else agrees. Left IM nail. Well, actually, guys, it's the other way around. So the dynamic hip screws on the left, the IM nails on the right. Remember, dynamic, DHS, yes, James, you've got another orthopod. Yeah, so remember the dynamic hip screw, it makes a bit more sense when you actually see it in movement, but the dynamic hip screw literally actually moves in and out. It's actually quite dynamic, whereas the IM nail is pretty static in terms of staying fixed within itself. Is intra the bone? Yes, nice. Yeah, as you see more of these, it'll make a bit more sense. But yeah, I found it quite interesting when actually seeing the dynamic hip screw movement. I'm sure there are videos out there on YouTube, so do have a look. And the last one here, total hip replacement, which you guys did say earlier. And as I was saying, if you can see in these images, both the acetabulum and the femoral head is replaced. So hemiarthroplasty and THR look very similar if you just glance at it, but always just hone in to see whether the acetabulum is also metal plated, and that will give you that differentiation between both. Brilliant. This is the last slide. Really quickly, guys, what sort of complications happen after hip replacements? Can happen. And kind of, obviously think it's a surgical procedure, so you can think generally about what sort of complications happen post-surgery. Bone doesn't grow into the replacement. Yes, the failure of the actual replacement. Exactly, good. Bleeding, nice, thank you, Celia, good. Celia tumors, oh, interesting. Okay, infection, big one. Heavy metals in blood. I think less common, but a possibility. Okay, cool, great suggestions, guys. So these are a bunch of them. Infection is a really, really important one. So what are the most common organisms in PGI, prosthetic joint infections? After any operation, yeah. So Niraj has put a good question there. Have I included that? No, I haven't. We'll come back to Niraj's question in a second. Good. Staph epidermidis. Nice. So when we were actually, myself and James were actually looking this up, and different sources say different things, but pretty much Staph aureus and Staph epidermidis are the big 2. Now, some said one was more than the other, and we saw very mixed reviews. But what I would say is just remember it as staph aureus and staph epidermidis. It does take a while for that biofilm, the staph epidermidis biofilm to kind of form on the prosthetic. So that's why I remember it as being more of a chronic infection and a bit more kind of a long-term thing that develops over time. But really well done. Those are the two. So do remember those. So Niraj was asking, what if people aren't mobile after a while, after an operation, after any operation really? I think he's going along the lines of blood clot is there. Niraj, I hope that's what you were going along. A frozen joint, possibly. That could happen as well. But yeah, remember that some of these complications apply to kind of, not just specifically hip replacements, but any kind of post-op surgery. And these are kind of useful things to know in any kind of OSCE scenario, common complications that can happen. But infections are a common one, especially in prosthetics. And, hip replacement is a big prosthetic joint operation that it's good to apply that knowledge to. Okay, cool. So thanks for staying, guys. I know it is 7 past. Sorry about having to rush a bit at the end. Please do give us feedback and let us know what you guys want more teaching on, and what topics you want us to cover, because we really do just want to teach you about stuff that you guys want to know more about and need, better teaching on essentially. So please do give us feedback, and thank you so much for hanging on 8 minutes past our finish time and engaging so well. It was really nice to have you guys.